Well, let's get started. This is the California Primary Care Association's webinar, and today's session will be on telehealth at community health centers. Can it work financially? I'm Mario Terras. I'm the director of the Center for Connected Health Policy, and with me today is Susan Phillip of Milliman Incorporated and Jason Cunningham, Medical Director of West County Health Centers. First, a few words about us. The Center for Connected Health Policy is an independent public interest organization, part of the Public Health Institute, and we are primarily about achieving health equity through use of technology. We do independent research, policy analysis, and provide education, and maintain a website with that information. We are one of 14 telehealth resource centers around the country. If you're not familiar with the California Telehealth Resource Center, they're located here in Sacramento, California, and we're funded by the Office of the National Advancement for Telehealth under HRSA. Our work is to provide assistance, both in terms of technical assistance and information and education, as well as hands-on support. So for any clinic that is interested in telehealth, please contact your telehealth resource center here in California. We also have one other national telehealth resource center that's based in Alaska, and their primary responsibility is in the area of technology. So they do objective analysis of peripherals such as electronic stethoscopes, as well as anything related to telehealth equipment, and their services are also available free of charge as well. Let's start from the basics. What is telehealth? As an advocate for social and health equity, we really believe that telehealth is about the means of enhancing quality healthcare, public health, and health education, and supporting this through the use of digital communications. In essence, it's providing healthcare at a distance. We specifically use the word telehealth, not telemedicine, because it does cover every aspect of healthcare. We've seen great advancements in teledental care, telemental health, and behavioral health, as well as social services, crisis intervention, and physical therapy. There are different modes of telehealth. So what most people are familiar with are the live video. So the use of high-speed internet and high-resolution cameras using secure telecommunications line to be able to provide outpatient consultation, say from a primary care physician to a specialist, or it could also be done from institution to institution. In this case, you're looking at a person who is a physician who is an intensivist working at a major medical center and connected to a rural hospital, providing a consultation for a child in intensive care. The second form of telehealth, not so well known as live video, is what's called store and forward. This is the use of sending digital images and information through high-speed, secure internet. So that the specialist can review that information at a later time in a much more efficient way than actually having to see them in their particular practice or office, and provide expert opinion or actually direct diagnosis. It's been most effectively used with dermatology, ophthalmology, for example, with retinopathy for diabetics, pathology, and radiology has been doing it for many, many years. Remote patient monitoring is a fast-growing area of telehealth. It's the use of various forms of peripherals to provide continuous information on various forms of biometric information. It could be as sophisticated as monitoring emergency rooms or in the home facility, particularly for helping people stay healthy at home, whether they're elderly or have some form of disability. And then there's this whole area of mobile health, which essentially means the use of internet through wireless technologies that allows you to really be free to move to anywhere to provide healthcare. Any form of telehealth, whether it's live video or store and forward, or remote monitoring, can be utilized using wireless technology in a way that really advances the ability to be flexible and essentially provide care anywhere. Today's session is really about how do we help community health centers advance into this world of telehealth. We understand that there are a number of obstacles and barriers and challenges related to cost-based reimbursement, access to this equipment, and also the fact that the rural health centers are not always in the best place to have high-speed broadband. So today's session is really more about a study that we conducted through the help of the California Blue Shield Foundation to allow us to do a financial study of health clinics that are already using telehealth to get at more of an understanding of what the true costs are. We also are cognizant of the fact that Senate Bill 147 is sitting on the governor's desk, which will allow for the testing of an alternative payment model. We believe this could be the real key for advancing the use of telehealth, given the fact that in a value-based world where you have flexibility and shared risk and also partnerships, that you can have any number of abilities to provide telehealth services as part of payments.
Oh, okay.
In a volume-based world where it's paid for services, as much like it is with the cost-based reimbursement, every one of these visits, whether it's in person or virtual, is at a cost. And so we believe that moving into this new world of value-based, that we'll be able to see greater advancements of telehealth. So very quickly, the project components, it was funded by the Blue Shield Foundation of California, and we were focused on working with 5 community health centers, 3 FQHCs and 2 rural health clinics based at rural hospitals that have had experience over a period of time using telehealth to get a better understanding of the true costs associated with that. Each clinic was different, had a very different mix of services, and we worked with 1 year's worth of data to prepare reports that could be useful for the ability to advance the uses of telehealth in the community health center world. These 2 reports that we're presenting here today are available on our website at www.cchpca.org. So what did we learn? We'll be going into greater details on this, but I think to hit on the high notes here, clearly we understand it's been a really slow uptake by community health centers and clinics, statewide as well as nationally, and that there's a real need for having a better, clear sense of what the costs are. We also know that you cannot just have a separate cost center for telehealth that has to be fully integrated into your healthcare delivery systems. And importantly, from our perspective as a policy center, significant changes need to happen in federal and state policy to allow for the kinds of billings and such with telehealth. So with that, I'll turn it over to Susan Phillip, who is the principal lead on our study, who worked with the 5 community health centers to do the in-depth analysis. Susan?
Great, thanks, Mario. Hi, everyone. My name is Susan Phillip. I'm a healthcare management consultant with Milliman. Milliman is an actuarial financial consulting firm. We work with health plans, including Medicaid managed care plans, as well as providers, foundations, research organizations, and other healthcare stakeholders on a variety of healthcare financing issues. I focus on payment and reimbursement models, especially under healthcare reform. So just want to thank CCHP for inviting me today and for CPCA for having us conduct this webinar. I'll be speaking about the analysis that Milliman conducted on how telehealth services are provided and financed at community health centers around California, specifically for the ones that participated in our study. I'll go to the next slide. Just a couple of quick caveats. First, our work was conducted based on data provided by the participating centers. And in some cases, we didn't receive complete data from all centers on telehealth services, so my presentation offers a partial view of all the telehealth services provided and their associated costs. However, the information we did receive gave us sufficient information to give us a sense of how telehealth services are financed among the centers participating in the study. Next slide. So the title of this webinar, I believe, is Telehealth and Community Health Centers Cannot Work Financially. And to jump to the punchline, I'll say, yes, it can be financially viable for community health centers. But of course, you know, there's always, you know, caveats here. As to quote one of our center leaders, telehealth really shouldn't be seen as a revenue generator. As Mario said, it really is a method of delivering necessary healthcare services and should be seen as part of the healthcare delivery system. And when you look at telehealth programs on their own, they are a cost center. And you'll see in the slides that I present today that that's the case for the participating centers. But there are strategies for improving revenue in the short term and for potentially enhancing telehealth adoption in the longer term, especially as we look at the new payment models under population-based models and value-based payment models. So what I'm going to talk about today is I'll quickly go over the project goals and approach. I'll give you a little bit of background context of community health centers and how they've historically used telehealth services. Then we'll get into our findings, which includes both challenges and potential solutions and opportunities. Okay, so to get into the project goals and approach, the goals of our project was to better understand the cost and reimbursement of telehealth services provided by the participating centers, and to examine the challenges they face and consider some opportunities for telehealth adoption, especially under evolving payment systems. Go to the next slide. So what we did first, CCHP and Milliman, we spent some time early in the project recruiting community health centers to participate. And ultimately, we did have 5 centers that participated: Shasta, Chapcare, Barton, West County, and Southern Inyo. And West County is here today to speak more in depth about their experience. So these 5 centers really actually represent a nice cross-section of California community health centers. They came from a variety of geographic locations. They included rural health centers and FQHCs. They serve a diverse patient population throughout California. They also represent a variety of structures. For example, we had a couple of counties that had multiple clinic sites in their respective counties and locales. Then we had a couple that also had hospitals and medical centers associated with their centers. So a nice cross-section. As part of the project, we collected information on the clinic side, so data on services provided in the clinic. We collected claims data where it was available, and then we also collected data on the telehealth program, administrative and programmatic operations related data. We did not get, this is really focused on the clinic side, so we did not obtain any services or information about services provided at the hospital on the inpatient or in ER settings. You know, before we get into the findings, just a couple of points of context here. Go to the next slide. Of course, as all of you know very well, community health centers are safety net providers by definition. This means they provide services to populations that are disproportionately underserved, uninsured, and have other barriers to access. For example, a population that's facing issues related to homelessness or mental health or addiction issues. And community health centers are also the primary source of care in communities in rural areas. The second point I wanted to make is community health centers have been, in many ways, pioneers in the area of telehealth. I mean, you've all heard the saying that necessity is the mother of invention. Well, for many centers, especially those in rural areas, telehealth was really the only viable method for providing access to necessary specialty services. For example, services such as psychiatric services or access to dermatologists. This especially applies for specialty services that are in short supply in certain areas. So I want to, if we go to the next slide. Okay, I wanted to touch a little bit on the various payment policies related to telehealth services. They do vary by payer sources. Many of you are aware of this, and the Center for Connected Health Policy produces a really excellent guide on telehealth payment policy. So I'm not going to get into a great deal of detail, but I do think it's important to point out a few key differences. For example, Medicare has certain restrictions in terms of the originating site, which means where the patient is located during the telehealth visit. Most notably, coverage is restricted just to rural areas. Medicare is fairly non-restrictive by contrast, and allows for coverage for a broader set of telehealth services, including store and forward technology, which Mario talked about a little earlier today. And commercial policies really do vary. We do see that they are rapidly evolving. Milliman provides consulting services to a variety of payers, and we see that many are considering or recently added telehealth benefits to their coverage because of employer or patient demand. So that's really rapidly changing these days. For the clinics that participated in our study, we find that Medi-Cal is the most dominant payer, and then next came Medicare, and then after that, commercial plans. So go to the next slide. So, if we go to the next slide there, that's good. So as I mentioned, most of the centers that participated in our study included a good variety in terms of population and other characteristics. They also varied in terms of the maturity of the telehealth program. We had a couple of centers that started, in the early 2000s, and others starting a little later in 2009, 2011. And I also think it was really interesting to point out that the centers in total provided a wide variety of specialty services through telehealth. Looking across here, there are about 15 different specialties or subspecialties, and they all provided 2 different modalities, live video and store and forward. Next slide. So this slide summarizes our findings, so I want to spend a little bit of time here. Based on all the claims and encounter information that we received, as well as the program revenue and cost information we collected, what do we find? First, this data represents either 2013 or 2014 data, depending on availability. We found that a couple of clinics had substantial number of telehealth encounters that were well over 1,000 encounters. And then there were a couple that had fairly low volume, not more than 100. I did want to note that for West County, we only received partial data, and that included either store and forward or consults for teledermatology. So we really only see a partial view of the services that they provide, but luckily we have Dr. Cunningham on the phone who can shed more light on the services that they do provide. So as you can see, what we have here in terms of total expenses, the total expenses do outstrip total revenue and grants. So for each of these centers, other sources of funding were used to subsidize the telehealth program. What makes up expenses? Expenses consist of payments to a distant provider, payments in terms of salary or benefits of the telehealth coordinator and related telehealth program staff. We also counted telehealth equipment, maintenance, broadband, and then revenues are from primarily 2 sources, either paid claims or from grants and donations that were primarily earmarked for the telehealth program. One of our participating centers, I wanted to point out, CHAPCare, used telehealth services primarily to provide access to specialty care to their uninsured population. So that's why you see no revenue generated for this program through claims. And I also wanted to point out a couple of points that are not on this slide. First, we found that for certain centers, there were opportunity for billing that weren't necessarily consistently used. For example, the originating site fee could be billed in certain situations, and we didn't see that necessarily being consistently, billed throughout. And while they're not huge amounts, originating site fees are generally around less than $30, about $22 or $28 in that range. But, you know, they could still add up. And we also found that in most situations, when it's possible and permitted, if it's most advantageous if the FQHC could bill the PPS rate for the visit under Medi-Cal. In that case, what tended to happen is for the visit itself, the cost for the visit was covered in its entirety. So in those situations, that was more advantageous for the FQHC. So I'm going to get a little bit now into some of the challenges and the themes that we heard from the centers. So we'll go to the next slide. So first, of course, there's volume challenges, which I've talked about, and you've seen in terms of the numbers. A couple of centers, as I mentioned, had low volume based on the data we were provided. So in a pure fee-for-service reimbursement system where payments are made based on volume, you know, long-term sustainability is a challenge. But however, as you all know, the underlying payment systems are changing and evolving, and those changes could create some real incentives for telehealth adoption. I'll get into that a little bit more. Provider contracting, we heard, was definitely an issue. Several centers had worked really hard over the years to develop contracts with distant providers, but we still saw a few key concerns. First, some providers are just not willing to work directly with Medi-Cal to be able to bill directly, and so in those instances, contracts have to be set up with the distant provider. And then we also saw that sometimes the negotiated rate with the distant provider may actually exceed the paid amount that the center receives for the telehealth encounter. So, you know, then for each encounter, it leads to a net loss for each visit. Again, where we saw kind of an exception to that was when the FQHC was reimbursed the PPS rate. And in those instances, the rates generally covered the cost of the distant provider.
Which time was that?
I'm sorry?
Which instance was that you thought that it was sustainable?
Well, those are specific situations in which the FQHC was billing the PPS rate, and then right. If the distant provider negotiated rate was less than the PPS rate, then, you know, just they're netting, either they're netting zero or they're, you know, netting a little bit of a net positive for that visit.
Okay.
So it's really encounter by encounter. Okay, so
what is the volume? I guess I'm not understanding the volume. The volume on the previous slide.
Yeah. So when we're talking about, well, if we get when we're talking about volume, what we mean by is the total number of telehealth encounters or total number of telehealth visits. That's what we mean by volume.
And so you're saying that model is not financially sustainable because of the lack of appointments?
Yeah, I mean, there's so few, generally speaking, there's so few telehealth encounters that generally, especially for a couple of clinics, that in and of itself, they can't cover the cost of the full program. So if you're just relying on telehealth revenue on a claims by claims basis to cover the cost of the program, the math doesn't work. So really, a lot of the centers are using other funding sources to cover the cost of the telehealth program as a whole. But other centers that have higher volume, they do a better job of getting close to breaking even. But again, as payment models are changing, you know, there could be other models for actually potentially increasing the use of telehealth while covering the cost. But it can't be done on a pure fee-for-service system.
Hi, this is CCHP, and we're just doing some of the technical stuff here on the webinar. Just mindful that we still have a speaker left. We would ask that all questions be held until the end. We will have time for Q&A, but if you do have a question that you think of right now, if you go to the bottom of the screen, put your pointer down there, there's a little chat function where you can type in your question. We'll definitely answer all questions towards the end. Just be mindful, if you do type in a question in the chat, that does go out to the entire audience. So if you wanted to direct it to somebody specifically, you're going to have to pick that person from the list. Otherwise, everybody will be able to see it. Sorry, Susan, go ahead.
Oh, no. Thanks, May. Okay, so then data management challenges. I already touched a little bit on this issue in terms of data collection for this project. You know, like mentioned, we didn't necessarily get claims or encounters for all telehealth encounters from all the clinics, but I think it's indicative of a larger issue of the ability of centers to track telehealth encounters. And generally speaking, it's useful for a center, particularly the telehealth program manager, to be able to understand the costs associated for the entire telehealth program, including what's paid to the distant provider, revenue from paid claims, and really get a sense of the total revenue cycle. It's useful for the telehealth program manager to be able to get a sense of that. But you know, sometimes this information is in multiple systems or not necessarily systematically tracked. So that's something that we noted there's room for improvement, and we would recommend that in systems that, especially in the EHR billing systems, there could be an additional code that's added to track telehealth encounters specifically. And we also saw one of the key themes that we heard from the centers, and you know, as in all of healthcare right now, there's lots of health IT competing priorities. There's transitions to EHR systems, transitioning to meaningful use standards. So sometimes, you know, just doing things like tracking telehealth is just not necessarily a priority. But at the same time, if there could be some internal tracking done in the EHR and billing systems, then the telehealth program manager could have a sense of the total cost of the program and exactly how much is being paid and what the revenue stream looks like. Okay, great. So, so I wanted to show this slide because I think it shows a little bit of the complexity of the billing rules and reimbursement policies related to telehealth. For example, there's various considerations for billing, such as the type of insurance the patient has, the modality of the telehealth service, where the patient is at the point of service, where the distant provider is, what type of provider that distant provider is, like, you know, for example, if they're a psychiatrist, or what specialty they are, and what the negotiated rate with that distant provider is. You know, but while sometimes getting a handle on this is daunting, you know, I think once a center has worked out a few scenarios and use cases on appropriate billing, then it can become more fairly routine and can be demystified. I do think that the California Telehealth Resource Center has some really great resources, including a pretty comprehensive reimbursement guide that walks through all the various scenarios. So I'm going to get to then the next slide, switch to some solutions and potential opportunities. So as I already mentioned, you know, better tracking of telehealth encounters can be beneficial, not only from a revenue perspective, but also to help inform operations and delivery system questions, to address the issue of volume, or, you know, low volume specifically, and the issue of complexity of billing and reimbursement. You know, one of the recommendations we had made was to consider developing a learning network that can be used as a forum to share best practices and address real practical questions regarding billing. Another potential solution is to bring several centers together to potentially pool the volume of patient visits to better negotiate contracts with distant providers, but also to allow the distant providers to have a more predictable volume and workload. For example, if several centers came together to contract with a telehealth vendor, there may be some economies of scale on both sides. So that was one potential solution for consideration. And then in terms of opportunities, if we go to the next slide, I wanted to close with discussion of opportunities to leverage telehealth activity as part of the drive to transform healthcare delivery and payment. You know, we're seeing a lot of activity on this on the national front, definitely on the state level. And so, of course, you've all heard about alternative payment methodologies. And alternative payment methodologies that allow for a per member per month payment rate may allow for some flexibility on how services are provided, and then could provide opportunities for more efficient delivery of care. And to the extent that telehealth is a more efficient delivery and appropriate model of service in specific circumstances, then that ought to be considered. The other consideration is use of telehealth to better manage care for patients with chronic conditions, to better manage post-hospital discharge. And we've seen some real innovations on this front. I know West County is going to be speaking about some of their specific efforts in this front, so I won't get into that. And then under Medicare, you know, we did make note that Medicare is the second payer for community health centers after Medi-Cal. And so Medicare has initiatives right now to drive volume-based payments to value-based payments. And again, there may be opportunities to leverage telehealth where it makes sense. For example, under Medicare's ACO programs, they are allowing for some waiver of telehealth restrictions, such as the requirement for the service to be provided in rural areas. So to the extent there is some flexibility, then telehealth might be a real, there might be some real opportunities for telehealth adoption to facilitate the provision of more efficient healthcare delivery. So I'm going to close with that because I know we're running short on time. So I will then turn it over to Jason Cunningham. Thank you.
Great, thank you. Pull up our slides here. So I'm here with actually Mary Seche is my medical director, my executive director, and I think to start with, to say that both of us have drank the primary care Kool-Aid fully, and I think I've bought into that telehealth offers a lot of solutions for primary care, not just in the traditional specialty access, but in collaboration and communication as well. So I'll speak to that a little bit. But also, not knowing exactly who's in the audience, I did want to comment on some of our more traditional stuff so that that can be part of the question and answer. We do use telehealth in the traditional model through primarily teleendocrinology, and we're initiating a telepsychiatry program, both of which are needed for access for our patients on those specialties, and are reaching out for other specialties as well. And then we've had good experience with David Wong and the direct dermatology, which is a store and forward. That is something, as was mentioned earlier, is something we do bill our PPS for, and it's something that our providers have found successful. And then lastly, on the specialty, particularly our teleendocrinology, we're bringing about half of the visits our primary care providers are in the visit with them. Right now it's in person with a patient, but in the future we're using a Polycom app to connect them virtually. And there is a way for that to be a compelling reason for the provider to be in and to bill. So if the specialty provider provides the consultation and the recommendations, the primary care provider receives those recommendations and then orders and so forth, then I think it's a useful way for billing both of those. But it's also, in my mind, a useful way for primary care to be in a collaborative relationship with specialty and to interpret that for the patient. So I put those out there just as part of our traditional use cases for future comments. But Mary and I thought it would be much more fun to talk about some of the future of healthcare and how we're using it in primary care. So we're going to focus a little bit on that today to spur on some conversation. So next slide. So almost all that we do in primary care happens around two basic principles for us. This is our favorite principle, that relationship is really our full product. It is literally all that we do. Everything is around that. So it's much more important to know what sort of patient has a disease than what sort of disease a patient has. That relationship and the model of relationship is how we gain trust. It's how we have continuity. It's how that patients receive our advice. And it's how that we walk through chronic illness with our patient. And as you'll see, we think that video offers more in relationship than some of the other ways that we communicate in primary care. And so certainly a way that telehealth can offer that. The next slide. So I couldn't resist. Primary care is a team sport. I'm from Michigan, so Michigan happens to be doing a little bit better, so I'll show them off. But we fully believe that primary care is a team sport, not an individual sport. And so as you'll see today, that video collaboration in a truest sense allows us to do primary care as a team sport, both within our organization across silos. And then as we get into some of the community models for warm handoffs and other things, we think video and video warm handoffs and video collaboration offers a lot of solutions for what we're being asked to do in primary care. Next slide. So I used to do OB. About 5 years ago, I stopped. To happen to be the same time that the iPhone happened. And so I just caught, this is the last patient I delivered, and I caught them texting in the newborn nursery. Oh my God, I was just got born. And so I brought it to Mary SHA, and we both said, my goodness, this offers us something that technology is actually in the world. This is not something that we need to provide $10,000 grants for, big Polycom carts, or these are things that technology is in the community. It's in smartphones, it's in tablets, that the video endpoint is no longer the barrier. And so you'll see that one of our big principles is that we bring off-the-shelf technology into the primary care space that's inexpensive. It's something we build into our budget and a normal process. It's not something that we have to have a significant outreach for grants or other dollars. So I wanted to show this off. One of our most, I think, significant innovations in technology, I think that we're going to make our millions eventually by coining the freakout factor in technology. There's something about putting technology into any existing workflow that there's a high freakout factor. And every technology innovation that we've done, that's the case. This one had a very low freakout factor. And so what we did is we brought in a product called Cisco Jabber. It was actually WebEx Connect at the time that we purchased it. And there are many others that do this. And basically, this product is a product we've downloaded. All of our 200 employees have it. It's a single sign-on. It allows everybody to be able to communicate with each other. And I've highlighted the corner here. There's a way for us to know that there's a presence within our staffing. So I know who's there. When they sign off a computer, they're no longer available. I know if that I'm, for instance, I usually put in clinic limited availability, so I will know that I'm available or not, or what type of availability. And then I can instant message, I can group instant message, I can video share my screen, and so forth across the organization. And here's an example of what I would consider technology and communication dramatically solving some of the barriers that we have. We initially implemented this because we were having our front office and back office having trouble communicating. And now instant message across our front office, back office. I use it in my exam room. We do it across our 6 different health centers. Was a significant value. And it's about $10 per license and very inexpensive. Next slide. So you're able to do a number of things with this, including instant messaging. And then next slide, we have then figured out that we can video escalate this. And so our video endpoint, our video technology at this point is an iPad in the rooms. It has a camera. All of our providers have that. So my provider can video chat, can instant message to my nurse across the building, to my specialty office, to my Forestville Wellness Center, to my executive director, and so forth. And that can be just back and forth, and I can escalate it from a chat to a video. And I say this to say that use of a very cheap in the room video endpoint with our other staff having just a $50 webcam on their computers, in my mind, is the solution to the future of primary care in its true collaborative sense. So I thought I'd show you a little bit of what we're doing with it, but this is our basic internal communication technology strategy. Next slide. So because iPads are mobile, we have a Verizon iPad that's our staff use outside the four walls. This is a picture of one of our nurses with a homeless patient doing a video communication with one of our staff back in the office. So here's a great example of nurses. If you're really looking at the future of primary care is outside the four walls, meeting patients where they're at transition care, homeless outreach workers, community health workers, and so forth, bringing a video endpoint out into the community and then videoing back into the primary care provider or a nurse or an access coordinator or some other useful staff member for communication. And also very inexpensive, and using this Cisco Jabber, it's something they know who's available, they know if they're available, and they can do an escalated video. And then we started this a number of years ago with a hospital who ended up closing, and now we're restarting it again, but it's a very compelling use case for us where we have a transition care nurse who rounds at our hospitals. She has an iPad, she does a communication with the hospital nurse, and then she video chats back with our transition care nurses at the primary care site to do a warm handoff from the primary care, or from the hospital nurse, our transition care nurse, and a patient back to our nurse, who then does the follow-up Coleman model transition for a home visit. And we have felt that this is a very compelling case. There's something that is communicated from a nurse to nurse that is not communicated in the discharge summary, and I get to know this person's, I think, is a high risk, or I ask the patient, what's really important to you upon your discharge? How can I meet those needs? And that video transition makes a big difference, both with understanding fully what's going on, but also that warm transfer of trust so that they agree for that home visit. Next slide. And then we do a lot of this. Commonly, I'm in the exam room, and I'm into my messy human relationship stuff. Going into the relationship is our primary product. When we really get into primary care, we're getting deeply into lives. We're asking them difficult questions. We're starting on difficult regimens. And I'll often do a warm handoff, just bringing the staff into the room with a nurse, with a behavioral health consult, with even a medical assistant or pharmacy tech. We're doing a lot of that now with video. So my nurse is across the parking lot. I'll bring my nurse in and say, I'd like to introduce you to Donna. She's wonderful. You know, to the patient, we had just talked about some deep issues here, including addiction. I just want to make sure all of us are on the same page. And there's Donna on the other end smiling, who then will make up the phone call later on. And we get to have a collaborative back and forth. And for us, that's met an important logistical issue with bringing people across the room. But it also, if we do it right, can have multiple people in the same room. So here's a picture of a patient that we're starting hepatitis C treatment with our pharmacy tech and a nurse and the primary care provider, all having a collaborative conversation. So here's an example where I think telehealth offers what primary care really needs to do, which is collaborative care on the real time. And then next slide. And the last thing I would say is that in exploring these type of things, I think that it's cheap, it's out of the box, but it also drives us to be able to do care outside of even our existing staff. So we're working with our hospitals, we're working with some of our community members, for food insecurity, for our homeless outreach grant, allowing us to do some of that collaboration and communication across system, which I think is also really a compelling from a primary care standpoint. So I'll end there. We're available for questions, and Mary Seche, again, my executive director, would have a lot to say around the billing and the strategic partnerships around this too.
Thank you, Jason. That was a great overview. Just before we get into the questions, we certainly would like your responses for those who have tuned into this webinar on Rating the Webinar. We're always looking to improve the presentations and the areas. So here's the link for that, and our website as well, and how to reach me. I wanted to go back to you, Jason, and just remind folks if they have questions, they can certainly type it into the chat box, and I'll ask the questions. Your approaches here, I think, really point out to the fact that this is more than just a diagnostic tool. That it really does improve effective communication between providers within the organization and externally. So, could you talk a bit about from the consumer perspective, how has this changed the way your clinical practice has been operating? And then also with external partners that you may have to collaborate with, which are not part of the clinic, but maybe specialists or other institutions that that you're doing warm handoffs with?
Sure.
What have they been their reactions?
Sure. I mean, I think that from the consumer point of view, again, this is not new to them anymore. I mean, across our spectrum of demographics, people have been exposed and are used to video as being part of their daily lives. My children communicate with their grandparents often during video. And so it is less scary to them than it may have been 5 or 6 years ago. We're testing this to a consumer point of view, even on areas that we don't think that we can get reimbursed. A classic one would be the patient at home alone with a primary care provider in their office. We don't think yet we can get billed for that, but a really compelling case of existing patient of mine who is going to take care of his mother in New Jersey, who is dying, was likely to spend about 6 years taking care of her before she passed, and had a very complicated medication regimen. I did a video chat with him once a month, and it was perfect. He did not have to establish with some other provider in that site, and it met a compelling need from a clinical point of view. So from a consumer point of view, I think that it really offers a lot. When we do these video warm handoffs, particularly if we have more than one person, 2 staff members and the patient, I always say they kind of feel like they're the CEO. There's a lot of people kind of talking with them about their needs, and it really is reassuring and impressive from the patient point of view. I've not found one patient that didn't feel like, wow, that was great, or that's really interesting. We do surveys afterwards, and overwhelmingly, it's been positive. We haven't had any real negative responses to that, particularly if we set it up. And then we do our traditional teleendocrinology, and then with telepsych, have both been, particularly endocrinology has met a real important need and have had strong consumer satisfaction with that. And then lastly, for our direct dermatology has also been very well received. I think the more interesting part of primary care, which is what I think primary care struggles with a lot, is how do we collaborate and communicate across silos? So the example for our warm handoff from the hospital's point of view, that seems like an easy use case for some of this technology. We have a board and care home, geriatric board and care facility that we have about 10 patients there. We gave them a WebEx Connect or a Jabber license, and so they communicate with our nurse, and then we escalate it to our geriatrologist or our family practice doc who takes care of the patients there. And so that's a really good example of just a clinical need. Is this cellulitis something we need to worry about? Or let's just get through the phones a lot easier so that person has direct communication with that nurse. So I think the warm handoff concept, we're bringing in a lawyer into our system to be able to offer services. That seems like a really compelling case to do a warm handoff back to them, from a screening to the outside in their office to do a warm handoff. Or food for thought we're working with. We're going to do video chats with them to introduce them, which is for food insecurity. I think there's a lot of warm handoff that can be, the patients trust me, and I'm giving that trust to a community partner, which I think will be very compelling.
You also talked about working with high-risk population, such as the homeless and frequent users of services and billers. One of the things that we were not able to get into in any real depth with the Milliman study was to be able to describe the cost avoidance, not only to your clinic, but to Medi-Cal and to hospitals and such. You have a sense in terms of certainly what impact you've had in reducing the emergency department visits and other cost avoidance that may have come from the program?
Yeah, so we do spend a lot of time right now, and I think all of primary care is moving that direction, focusing on our high-cost outliers or our high-risk outliers. Homeless is a good example of that. Excuse my phone ringing in the background. And we think that the patient's home environment is very important in that communication. And so being able to have the staff member at home looking at the existing environment, understanding what the risks are, understanding what the barriers are very compelling. And that person then communicates back to either the primary care provider or, more interestingly, I think for other resources, our access coordinators, our community health workers, our resource social workers, and so forth, I think will be a compelling use case to meet the need for what the patients have and the reason that they're high cost. We've proven that we've reduced the inpatient and the ER visits, and our return on investment for the money that, for instance, Partnership Health Plan has given us has been significant. And I think not that telehealth is the answer, but telehealth meets a need within that communication or that collaboration that truly is necessary. I really feel like that's a compelling use of telehealth. Again, not because telehealth will be paid for, but because without telehealth, it's a lot more difficult to do the real-time collaboration across silos within our systems. So we're certainly using that heavily in that model.
Terrific. I also had I wanted to go a little deeper with you, Susan. One of the real benefits that came out of the study was to understand how to account for the costs of telehealth as part of the delivery of care, as opposed to being a separate cost center. Can you talk about that a little bit more in detail, and what kind of recommendations and suggestions you can make based on what you saw in these five pilots?
Yeah, I think actually the example that West County gave is really perfect. You know, I think what we weren't, which is not the types of innovative services that are currently being done in the centers, and we see across healthcare right now, are not typically paid for on a fee-for-service basis, like telehealth or health IT-enabled care management solutions, telehealth that supports a care manager, and where we've seen those types of innovations, again, those are not necessarily paid for on a fee-for-service basis. However, you know, as we're moving to more value-based and population-based payment models, which include a per member per month payment, there's more opportunities and flexibility for testing those types of innovations. We see that there are, for example, medical groups and practices that have, for example, have gotten care management fees from payers, and they're using certain care management and care coordination type fees to explore and build a capacity for things like care management solutions, which could include telehealth. So I think those are a couple of you know, great examples where we're seeing more innovation and testing in the telehealth space that's enabled by increased flexibility in the payment model that actually is trying to reward outcomes and value.
Great. Let me see if anybody else has any other questions. You're welcome to ask directly. You just pick up the phone, or just send it in by chat.
We will be unmuting all the participants, so you can just ask directly as well. But if you don't have any questions, we would appreciate if you can just go ahead and put themselves on mute to keep the background noise down. Thank you.
Uh-oh. So, are there any questions? Does anybody have any questions?
There they have a bunch of different, like document examples. They have the different
We're getting a little bit of feedback. If you do not have a question, would you?
All right. So I think we need to mute everybody. Just use the chat box.
Okay, we have muted everyone. Mario, I'm unmuting you.
Were you able to hear the question that came in?
I did not. Whoever had a question, if you could type it into the chat box.
In the meantime, let me just say that we have, we're doing a second study now funded by the Blue Shield Foundation of California to explore another form of using technology for patient care that is not full telehealth, but using electronic consult or e-consult that it's called, to be able to provide an alternative means for a primary care provider to essentially triage with a specialist using web-based secure communication to determine whether or not a referral needs to be made. This is a very promising practice that we've seen in LA and San Francisco, and we're looking to see how it can be expanded across the state, also across the country, in the sense that it is not only a time saver, it's a money saver, but it also helps to enrich the primary care provider team, and being able to have the expert consultation and opinion. It's not a diagnostic service, and several payers are really seriously interested in this as a way of helping to deal with the timely access question. And so that report will be available sometime in early spring, and hopefully we'll be able to do another follow-up webinar to go deeper into that, as well as the Project Echo model, which has also become very popular.
Once again, if you have a question, if you go down to the bottom of your screen, put your cursor down there, a toolbar should pop up and the chat function should appear. Just click on that and you can type in your question.
All right. Well, I think with that, I want to remind folks that the detailed report we just gave you, the highlights of the Milliman study, is available on the CCHP website, as well as a summary report and recommendations for community health centers that we're using both with CPCA and with rural health clinic advocates to help advance policy and practice related to the uses of these very exciting new technologies that really do allow us to do care everywhere. And so with that, thank you so much to Susan and to Jason and to you for listening in. And with that, we'll sign off.
Thank you.
And thank you to CPCA for helping us co-host this.